So Mark, we are about to do something called Periscope on Twitter. Are you on Twitter?
I am.
You have any idea what Periscope is?
I have a sense.
It's like Facebook Live except it's on Twitter. So we've got some friends out there that are watching us and they're expecting us to tell them what's happening at AHA 2018 here in Chicago, and we're in the Northwestern booth.
Yes,
I mean,
we
this
are.
is great. Look
It
at
is
this
cool.
place.
It
Yeah.
is very cool.
So, all kidding aside, this is a great meeting. It just got started, but it's a great meeting because it's endorsing so many things that we know to be correct in cardiovascular medicine, introducing us to new ideas. But now you come from the cath lab, structural heart disease interventions. What are you looking forward to at this meeting? What have you thought about? What do you hope emerges from this meeting?
Yeah. Well, we talked a little bit earlier about how there are so many meetings out there, and some of them are very focused on different aspects of our field. And I think we do look to AHA to bring this all together in some ways, to go all the way from prevention to intervention, as opposed to some of the more specialized meetings that focus really just on one of those aspects.
So that's a great way to start. So why don't we take a step back before we come forward? Let's go back to September. TCT meeting, COAPT, you're front and center.
Yeah.
What was the story, and what do we do now 2 months later with the COAPT data? The guy that's listening to us on Twitter, and I use guy generically, men and women,
Oh yeah.
and say, look, what do you do with this information? We got this great study, but now what happens next?
Yeah. Yeah, well, it is amazing because we had this huge lead up to the results being announced at the trial, because it was a very vigorous trial. It took a lot of work to enroll patients. It occurred over a 5-year time span. So there's a lot of build up to it. And then we get these tremendous results, very positive when you look at functional mitral regurgitation patients with heart failure, and the tremendous reductions in heart failure admissions and improvement in mortality. So you have the results, and you have the patients because they represent fully 3/4 at least of all the patients with severe symptomatic MR out there. And yet we don't have a label, we don't have a real mechanism to do this without FDA approval and everything that comes with it.
We don't have a guideline yet.
And we don't have a guideline yet. And obviously now, I think a lot of the discussion now is, well, how do we incorporate this into our practice? Do we wait for more trials? Is this definitive? And I think that's where all the discussion that I'm hearing anyway is about how do we use this information to take care of our patients, because they were startlingly positive.
Yeah, and from my point of view, because the patient population was so intently focused on heart failure, and the requirement for exposure to evidence-based medical therapy was so high, it was a wonderful testament to, one, the benefit of evidence-based medical therapy, and two, the prognosis. If you can't tolerate or you don't respond to evidence-based therapy, something needs to be done.
Yeah, right.
And I was really pleased to see that.
Yeah.
So that gets us to the AHA meeting. There are a lot of themes here to deal with the more global burden of heart disease, including valvular heart disease, but there's a lot of stuff coming out today about prevention, but there's also some very intriguing data coming out later this weekend about a novel way of dealing with your particular space, ACS, acute care for those that are threatening an MI. There is a special trial being done that's testing the hypothesis of ischemic preconditioning and using mechanical circulatory support before revascularization. So let's deconstruct this. What is ischemic preconditioning?
Well, I think that follows the line of thinking that the heart and all of its complexity metabolically depends on obviously blood flow and oxygenation, but there are things that happen when the heart muscle itself is exposed to ischemia that may allow it to respond better to a more ischemic event down the road. And so there's the concept of ischemic preconditioning related to the heart itself and its heart muscle. There's remote preconditioning. There's even a concept of post-conditioning, but it's the concept that the heart can be conditioned and readied for an event like an occluded artery.
And so one of the very basic tenets here is there a phenomenon that releases the free radical scavengers in anticipation of the injury, in this case, the reperfusion? And if so, would that make a big difference? But this is a very different approach. Now, placing an impeller, mechanical circulatory support, in the setting of a STEMI, an anterior wall STEMI. Okay, like stop the presses. I thought we had figured out how to treat an anterior wall STEMI. But again, with my lens of heart failure, I know that there's still those patients that end up with terrible LV function after an acute STEMI, even when they're revascularized appropriately. So what do you think about this approach?
Well, first of all, it's fascinating because it's anathema to everything we think about when we're talking about an occluded artery. See, an occluded artery, it's got to be open. It's got to be open immediately in the acute ACS setting. So, and many of us have been trained in this way. It's a big part of everybody's practice who does interventional cardiology. It's why you're on call at night, is to respond quickly and efficiently.
I think it's even more than training now. It's like acculturation. I mean, I'm not in the lab, and I still think of this. I mean, if I around in the CCU, I expect patients got revascularized or else.
Yeah, you get jazzed up for it.
Yeah.
And but I think that would be such a change in how we practice. I think it'd be very difficult to do a trial like that because you're asking a cheetah to stroll towards its prey. You know what I mean? You're ready.
Okay.
Your system.
Can we just restate that? You're asking a cheetah, CHEETAH, to stroll, not leap on his prey.
Yeah.
That's notable. Yeah. That's good.
Because we're so geared up for this, the whole team. The nurses, the techs, everybody's, let's go do this.
Yeah, but what happens if you can digest the prey better by strolling instead of leaping? But let's get back on point. So what kind of result would you need to see to be convinced that it is worth pausing, that it is worth placing a device to precondition the myocardium?
Yeah. Well, I think, we need the evidence. And I think the big question is, will people be comfortable enough to actually participate in a trial like that? And I think
so. Equipoise.
Yeah, exactly. And but if you think about, if you were to really look carefully at time to reperfusion, we know that time matters, but we also know that although it's linear, that there are things you can do that affect the change prior to opening an artery. That's just the reality.
And it also looks like we've hit a plateau. Because as we were decreasing door to balloon time, and we saw an improvement in outcomes, and now outcomes are as they are, suggesting that a further decrease in door to balloon time may not be yet. We've talked about onset of symptoms to balloon time, but this is a very interesting idea of getting in there regardless of when the symptoms occurred and protecting the myocardium first. As a muscle guy, I like the idea of protecting the muscle because that's the entire consequence of the heart attack. The entire consequence.
Yeah, it's very true. And I think the reality is maybe the quote easier way to study this would be to take the patient's arteries in the throes of active heart failure and shock. But that may be when the cat's already at the bag, huh?
Exactly, because we know the shock trials. Whether it's a balloon pump or any of a number of other devices, we can't see that signal. No. Is this a better approach? Then we have to acknowledge that what's the additional cost, the additional harm that might come from the immediacy of an acute MI trying to place a device. So let's kind of get to a point of some takeaways for our listeners. Like any American Heart Association meeting, we're talking about prevention. And for those of you listening right now, pay attention to the earlier Periscope program we did with Dr. Bono about prevention. Some great stuff coming out about prevention. Now we're thinking more about treatment. So just give us some takeaways that are the evident observations today for someone presenting with an acute MI, a STEMI. What are the takeaways right now?
Well, I think it's the typical AHA thing, isn't it? It goes everywhere from prevention. We have a lot of lipid stuff going on at this meeting this week. And then when it comes to acute heart attack care, I think we are now getting, hopefully, reinvigorated about, you used the word plateau, and I think that's very true. I think this has been very dumbed down, the management of ACS. Positive troponin, positive ECG, go and open the artery, put them on statins, get them home in 2 days, put them in rehab, we're done. But it's clear that, and you know this certainly as a heart failure person, and we talked about COAPT before, where fully 2/3 of the people had ischemic MR, our goal really has to be to protect the heart any way we can. And I think this trial just exemplifies it probably better than most because it's taken the heart first and talking about circulation secondary.
Yeah, but I think regardless, time still matters most.
Absolutely, no.
And until something else happens, get them into the lab as quickly as possible, get the infarct-related artery open as quickly as possible, and don't forget the secondary prevention stuff.
Yeah.
That's important.
Oh my God, yeah.
Yeah.
Absolutely.
All right, man. Listen,
great.
So fun to talk to you.
Very nice. Same here.
Really appreciate your attention to Periscope today. Stay tuned for more information coming from AHA 2018. courtesy of the Northwestern Medicine Purple booth.